So now I give over to Dr. Frans Cronje. He has given the talk last year, very entertaining, about this project that he initiated. He called it the Genomic Research and Advancing Clinical Excellence, and his talk of last year is also on the YouTube. So I'm looking very much forward to your talk today.
Thanks, Marita. Well, it's always towards the end of the day that one really wonders what one took in and what one will take forward. And I'm someone who tends to think. Sometimes I wonder whether I'm not more a medical philosopher than a doctor, because so much of what we are about is trying to do the right thing for patients at the right time and the right way. And someone described me as having sort of a divine dissatisfaction, which was believing that there should be a better way to do things, but often really struggling to find what that should be. And as I mentioned previously, Marita threw me into the concept of trying to extend the genomic medical realm into advancing clinical excellence, and that really remains a passion for me. But I've recently reframed it, because so much of what we talk about in medicine is about evidence and evidence and evidence and evidence. But what we don't realize is that the pursuit of evidence is merely a tool for what we ultimately require, which is confidence. Because evidence is the way in which we research or gain information, whereupon we then confidently introduce something as a remedy, in which ideally the patient will also have confidence. And what I'd like to submit to you today is that I believe that genomic medicine is able to restore some of the confidence that healthcare has lost. And if you understand that and leverage that and frame shift from evidence to confidence, it changes and legitimizes good bedside manner, the way in which you discuss data, the way you understand your role as a health coach. It changes everything. And I hope that that's really the take-home message. The rest is just commentary. So let me start by saying that our whole understanding of disease has changed, and we're moving from the acute communicable diseases and conditions into a world that really is becoming more and more chronically ill. And therefore the strategies of anti-infectives and the emergency medical strategies that really have been some of the pinnacles of medicine are now becoming some of the embarrassments, because we can do the most miraculous things in acute settings, but we can do so little in chronic conditions. Medicine is being confronted, we're being overtaxed, we have too few resources, it's an ongoing struggle with finances, we have this concern that what we are doing is not sufficiently evidence-based, and of course rightly so, because we need to be confident, because if we're not confident we won't be effective in the therapeutic interaction. In fact, doctor confidence is one of the most significant variables in a patient encounter. Even if you're confident about a patient possibly getting, amidst a placebo or something else, an active substance in which you have faith, then the patients respond better to the placebo. All right? In other words, if you are simply confident in the interaction, then it transfers into that encounter. We should not underestimate this. Now, unfortunately, the dark side of the pursuit of evidence is scientism, where we simply demand that if we do not understand something, it doesn't exist. And that unfortunately has driven a lot of our attitudes, and it's often introduced negative placebo effects. In other words, when we speak to a patient, we will undermine our own confidence in whatever we're doing, because we say, well, there isn't sufficient evidence, and there haven't been these trials, and this, that, and the other. And of course that's true. But if it undermines confidence, it is to the detriment of the therapeutic process. And that is fact. Now, we of course have the things that we are very grateful that we know. There are many things that we know we don't know, and we heard a lot about that today. Sadly, there are also those things that we think we know that aren't so. And they are the barriers to progress. But there's an even bigger world of what we don't know we don't know. And we need to be humble and curious in our pursuit, understanding that each patient is an opportunity for discovery. And that's perhaps one of the most exciting aspects of this genomic world. Each encounter is an opportunity for discovery. And now that we're challenged by aging, poor, diseased people, and in a neuroscientific world where we suddenly are being confronted with certain immaterial aspects of what the mind does, we are also forced to change our understanding of evidence-based medicine. And this classic review by Sackett in the British Medical Journal in '96 made provision for patient values and expectations in the construct for evidence-based medicine. But I submit to you that a patient value is not evidence. And therefore I think that this is already a flawed construct, and what it's trying to depict, rightly so, is confidence. We need to have a confident healthcare encounter. And the patient's values and expectations are their response to our confidence, is their response to their confidence in the healthcare system. Now, what do we do with this? Well, first of all, patients consider themselves as 100% of whatever the statistic is because it applies to them. You know, if your chances of a shark bite is 1%, it matters very little if you're the one that's bitten. Okay, so for them, this is 100% of their world. They don't see the Gauss curve. They see themselves as an outlier, isolated in that. They also have a body, soul, and spirit understanding. I hoped you'd like that. They have a broader understanding of their world and how they integrate their health and illness within that framework, even if you are only working at that level. They're confronted and confused with information where the next You magazine or advertisements will propel them into a new direction of trying to gain control over an illness or condition that they understand very poorly, conflicting evidence driving them like the wind drives a sailboat. And into this confusion, I've certainly found that there's a certain groundedness that the genomic world has brought. It is legitimized and it has even dignified the person's experience. It is often simultaneously given them an understanding for their vulnerability, whilst at the same time empowering them towards a solution. And I have found that a magnificent dynamic. The strange pursuit of patients in medicine is depicted in the slide, where 2000 BC it was eat this root, 1000 BC, no, the root is heathen, say this prayer, 1850 the prayer is superstitious, drink this potion, 1940, oh no, swallow this pill, 1985, take this potent antibiotic, oh no, the antibiotic's artificial, eat this root. And so the culture has changed as people's confidence has changed, and the confidence in the remedy has changed. It's not only evidence, it is confidence. And so in the pursuit of health, of course, we focus in our world on pathogens, predisposition, and pathophysiology. That eventually becomes classified as a disorder or disease. We then follow strategies depending on our stream or tribe of healthcare, in which we either oppose the disease, support the patient, or interrupt the pathway under various different means, recognizing that there's something above that which we usually farm out to neurobiologists or psychiatrists or psychologists, and ultimately realize that there's something even above that. But if this is even entertained, we don't really integrate that within the overall care of a patient, with the possible exception of entertaining religious preferences in their healthcare encounter. But we don't really understand the full whole. What has come closest to trying to deal with this is maybe the functional medicine model, where the root causes that include genetics and environments are understood, where there are core imbalances and dysfunctions, which you will see in the wellness screen, are the areas that are really strategically focused. And then ultimately the fruit of all this dysfunction manifesting as overt disease, which is then farmed out to the various specialties. So that is certainly more encouraging. And within these pathways, we can see that the immunity and inflammation, hormones, neurotransmitters, detoxification, all these things are very much relevant to all these multifactorial, multi-genetic areas that we are indeed trying to poll. And as I said, the wellness screen has been so useful in often convincing people and showing people that the good advice that their grandmother could have given them is really also true for them. Eat your broccoli, do your exercise, get enough sleep. But fortunately, and I don't want to reduce this to a level of merely a tool for convincing people, it makes it up close and personal. It engenders commitment from them, and it transforms people's motivation to engage. And that is marvelous. Now, as I said, I'm a bit of a philosopher, and I would like to share with you just a framework to broaden the way you maybe think about these things. In our physical world, we have information, matter, and energy in various forms. We have it, for instance, genomics would fit in information. We have proteomics in the matter, and we have metabolomics in energy. We naturally construct our physical worlds within those categories. I'll show you just now it even happens embryologically, how the human organism develops within those themes. But those give us mechanism. Those give us the laws of nature that apply like almost a mechanism or a fairly predictable system. But if we move up a level to the level of what we would call the soul or the psyche, this is where we have a more relational framework. And this is where the nature-nurture debate comes in. And we look at it as nature-nurture, but I'd like to reframe that and use the term resource for what we are given and relationship for our interactions, adding the third component that we don't necessarily recognize, which is the ritual. Because you see, when we have a meaningful experience, you and I, in relationship, go and have coffee together. So we combine a relationship, a resource, in a ritual or a routine, and the meaning of our life is typically made up of those things. In fact, advertisements say, well, you've got the girl. You know you want to go on that hike, but you just need the 4x4, okay? And then you'll have meaning. And that is the natural construct of the soul. It requires an interpretation and appreciation, which is at the level of meaning. And this is, of course, the placebo effect. And I do not want to diminish the placebo in a sugar pill to bamboozle a patient. What I want to show you in this headache study is a placebo versus a placebo-branded aspirin had different effects. Moreover, when they had an unbranded active pill, active aspirin, and a branded one, the branded one was better. So that's not really placebo, that's confidence, that's meaning. That's at a different level than mechanism. Do you see that? Okay. Now when it gets to the spiritual is very woolly, and you get a lot of contradictions. You've got Leo Rosten say it's not about being happy, it's about being productive, and you've got the Dalai Lama saying that it's all about being happy. So that doesn't really clarify it very well. What I will say is that the same dynamics of relationship, which would usually in the spiritual context be described as mysticism, in other words, the pursuit of the divine or divine knowledge or divine interaction or sacred relationship, which would be the information pathway. You've got the behavioral constructs that are very heavily predisposed towards the ritualistic, and then you've got the experiential, hug a tree, sniff of this, or rub a crystal or something, that would be within the more experiential dimensions. And I'm not meaning to be derogatory about it, I'm just trying to illustrate it. So this is the animating part of us. The spiritual is the animating part. It's what drives us. It's if a high-spirited person is a person who's intense, right? So that's a driving force, and that is not at the level of the soul, it's at the level of the spirit, as we define it at least. Okay, so we've actually got different levels, and if we don't understand that, then it becomes confusing. Now, let me show you in our human triunity, if I could call it that, how you could break that out. Because you see, our relational part, we've got a capacity for at least spiritual relating, at some level. We've got a capacity for thought, and we've also got ectoderm in the embryo, which is all the signaling tissues, brain, face, all the senses, nervous system, everything that signals information is related to that pathway, ectoderm. Conscience, will, and mesoderm have to do with behavior. That's whether you should, this is whether you will, and that's how you actually do it, because that's the muscles and joints and things, the substance that actually moves in the process of doing something. Similarly, the experiential or the receiving part, spiritually we call it intuition, emotion in the soul, and gut feel in the body, right? Where do you feel it? You feel it in the gut. So we know that the internal environment is all influenced in this way. Now let me just show you quickly how wonderful this construct is. Ecto, meso, endoderm. These are the tissues. Ectoderm signaling, mesoderm substance, even heart and kidneys, endoderm energy, oxygen in and out, metabolism, etc. So it's information, matter, and energy as a theme. Why I'm mentioning this to you is I think that those in bioinformatics, it will be very helpful to start thinking about these things in relation to similar constructs. I know it's oversimplified, there's a lot of interaction, but it's very useful to start thinking because disease patterns parallel a lot of these things. Okay, now let me bring it back to brass tacks. The patient encounter is critical. We tend to focus on remedy, but the reality is the transforming agent is the relationship. You can go to the first example that I could find in the Bible, which is basically Abimelech and Abraham, where Abraham prays for Abimelech, his fertility is restored, and immediately thereafter Sarah becomes pregnant. So there's this interaction of a meaningful encounter in a relationship that ultimately restores them to homeostasis. Perhaps you're more familiar with Job. Job's fate changes when he has a meaningful interaction with his friends. So there's that significant therapeutic encounter within the context of a relationship. And I would submit to you that genomics gives you a unique, profound opportunity to relate and to build confidence in the health process. Healing is always relational, whether it's between an antigen presenting cell and a T cell, whether it's between children and adults, or whether it's between elderly people. It's always relational. So whether you ultimately, through the process of engaging in this genomic world, serve as a coach, serve as someone who does surveillance, serve as someone who does intervention based on the genomic and genetic information, I would remind you that the relationship is not an inert substance. It is perhaps the most significant substance of all. Because confidence, yes, includes the evidence. Yes, includes what we have experienced. Yes, considers other possibilities. Yes, must be intrinsically effective. Should be done with good character. Should be done with a mind for what it costs. And ultimately needs the partnering of the patient. That makes up confidence and confidence-based healthcare. Now, where do I start with my colleagues? In the interest of time, I won't dwell on the priorities with chronic disease other than to say that we need knowledgeable patients, collaborative doctors, changes in our systems, new modes of practice, and many that already have been demonstrated to work that simply just need to be employed. We also need students and doctors exposed to different settings, learning how to educate patients in self-management. And I think the wellness report, for instance, that Marita has put together is such an empowering way of equipping patients. So I think it needs to be refined. I think it needs to be built into broader frameworks of coaching. But it is such a profound start in achieving self-management. Understanding group dynamics, allowing patients to learn from each other and us from them, sharing in the management, integrating care, finding a platform. And I really hope that the database ultimately could become a management platform. We need a way to communicate outside of WhatsApp, BBM, and the occasional email, because we never find one another on the phone. Non-clinical encounter modalities are the way we are going to need to relate, and we will have to find ways to do it more effectively, because ultimately it's about quality of life. So when speaking to colleagues, realizing that this is a very complex world, and they ask me, when should they think of genetic testing? I say, well, worst case scenario, the weird, the idiosyncratic response to what you would not have expected. The opposite, the paradoxical response to a medicine where someone has a completely unanticipated and in fact in some ways an opposite response, is a prompt for me. When you have critical decisions to make about risk-benefit, chemotherapy perhaps being the most poignant example, when you have a stubborn situation, not necessarily a stubborn patient, although genomics is helpful there as well, but a stubborn situation, genomics can allow you and afford you to retain the person's confidence in the system, because you're looking at what their problem is. You're not giving them a cookbook recipe based on other people. And then finally, as part of the training encounter of what is important for them, what is it that would make a difference in their lives? How can they rationalize their own self-care? And those are things that I think will transform a propensity towards technology and bioinformation into something that nevertheless is relationally built and ultimately truly personalized. Thank you very much.